Hello, my dear curious and studious students of surgery. Myself, Dr. Mahesh Chaudhary. I am warm welcoming you in my surgery lecture series. This surgery lecture series contains entire surgery with anesthesia, with radiology, with orthopedic. So stay tuned with us. Let's start our surgery lecture series. Welcome, my dear students, in my surgery lecture number 116, that is the disease of the neck. In this lecture, we will cover the cystic hygroma, thyroglossal cyst, thyroglossal fistula, cold abscess in the neck, cholesterol abscess, and laryngocele. All these points are covered in this lecture. Now, start with the disease of the neck. First is the cystic hygroma. It is a cystic swelling which contains multiple locules of clear lymph. The pathology of this cystic hygroma is the swelling consists of aggregation of the cyst which contains the clear lymph. It can be considered as a multilocular swelling containing clear lymph. Each locule is lined by a single layer of the endothelium. That is why this swelling is a brilliantly translucent swelling. Many locules or cysts may intercommunicate with one another. Cystic hygroma may infiltrate into the muscles planes and these extensions may grow deep. Dear students, here is a good picture of the cystic hygroma is clearly seen on your screen. Now the site of the cystic hygroma, posterior triangle of the neck is commonest site. The swelling gradually extends upward and towards the ear or downwards towards the axilla. The swelling may attain such a huge size and it becomes difficult to know which is the actual site of the origin. It is few textbooks. It is described as an anterior triangle swelling in the cheek, in the axilla, in the groin, and in the mediastinum. The groin mediastinum is the very rarely. These sites should be carefully looked for such swellings. Now the clinical features. Age. It is the earliest swellings one can see in the neck. It manifests in early infancy. Occasionally it is the present at birth. Rarely it may be present before birth, and if attains a large size may obstruct labor. Symptoms of the cystic hygroma is the only symptoms is the lump and or swelling. The parent bring the children for disfigurement to the doctors. Local examination. Site. Its usual position is at the lower third of the neck in the posterior triangle. Size and shape. The size varies extremely. It is usually round in shape and smooth in distinct margin which yields to the palpating fingers. Surface is smooth or lobulated. When multiple cyst or lacuna remains very near the surface, it may be lobulated. Usually large cyst remains towards the surface and gives a smooth surface. Consistency. It is extremely soft and cystic and fluctuation test is positive. Impulse on cupping. This swelling gives an impulse on cupping. When the child cups or cries, the swelling visibly increases the size. Compressibility. The swelling is partially compressible as the fluid is one loculus passes into the others, but this cannot be reduced. Translucency test. It is the brilliantly translucent swelling and this is the important for the different diagnosis. During this test, multiple septi may be noticed. Renal lymph nodes are not enlarged. Now the complications of these conditions, that is the cystic hygroma, are sometimes the growth is extremely rapid and may cause respiratory difficulty. In this case, immediate aspiration of as much content as possible is necessary. Tracheostomy may be required if this does not relieve respiratory difficulty. Swelling may become infected as the result of the nasopharyngeal infection. Spontaneous recovery may take place, particularly when the swelling becomes inflamed. Subsequent fibrosis will help spontaneous regression. Now the treatment of the cystic hygroma are: excision is the treatment of choice. Such excision may be delayed under the strict follow-up till the child attains a reasonable age for excision. Preliminary injections of the boiling water into the cyst at weekly intervals will cause regression of the swelling to a certain extent. The cyst wall becomes more fibrous. This should be followed by excision of the cyst. Preliminary injection will facilitate dissection. One must be careful to excise all the extensions through the muscle planes. Dangers of incomplete removal. It may cause recurrence. Continuous fluid and electrolytes loss through the open cyst will cause dehydration of the child. It may lead to open infection. Radiotherapy may be tried in case of the recurrence, and when surgery is not possible, this swelling is radio resistant and hardly acts to the radiotherapy. Now the next entity of this lecture is the thyroglossal cyst. It is a cystic swelling developed in the remnant of the thyroglossal tract. Development of this thyroglossal cyst from the ventral portion of the ectoderm between the first and second branchial arch, a diverticulum extends downwards and forms the median thyroid diverticulum. This diverticulum moves downwards and comes in front of the thyroid cartilage to form the isthmus and pyramidal lobe of the thyroid gland. This tract is known as the thyroglossal tract. The course of this thyroglossal tract or duct, the thyroglossal duct passes down from the foramen cecum of the tongue between the genioglossae muscles. Then it passes along the midline downwards. It descends either in front of the hyoid bone or through the hyoid bone, or it hooks below and behind the hyoid bones and then descends downwards along the midline to the upper border of the thyroid cartilage. It then moves slightly to the left and ultimately ends in the pyramidal lobe of the thyroid gland. Dear students, here is a good picture on your screen you are watching. This is the thyroglossal cyst. This is the lateral view, animated picture of the thyroglossal cyst. Ultimate fate of the thyroglossal duct. From the origin of the duct in the foramen cecum, ectopic thyroid tissue may develop and form the lingual thyroid. This lingual thyroid is a red rounded swelling at the back of the tongue at the foramen cecum. It may represent the only thyroid tissue represent. The entire duct usually disappears except the lower portion which forms the isthmus of the thyroid gland and the pyramidal lobe. The upper portion of the duct from the foramen cecum to the hyoid bone may disappear, but the rest of the duct or tract persists as the levator glandulae thyroidae. While the tract disappears, a portion of the duct may remain patent, which gives rise to a cystic swelling due to the accumulation of the secretions, and this is known as the thyroglossal cyst. This is an example of the tubulodermoid. An ectopic thyroid may occupy a subhyoid position in the midline and stimulate a thyroglossal cyst. It may be the only thyroid tissue present in the body. Now the pathology of the thyroglossal cyst are: the thyroglossal cyst is lined by the pseudostratified ciliated columnar epithelium. There may be squamous lining and mucous glands. There may be some lymphoid tissues outside the epithelial lining for which this cyst is prone to become infected. It may contain thyroid tissues. The content are easily mucoid and become thickened by discomated epithelial cells or debris. Cholesterol crystals may be present. Carcinomatous changes may occur in the thyroglossal cyst. Now the clinical features of the thyroglossal cyst are: age. Thyroglossal cyst may appear at any age, but majority of the patients are between the 15 to 30 years of age. The cyst is more commonly seen in the women. Now the symptoms. The commonest symptoms is the painless swelling in the neck. It is usually a midline swelling except when it is below the thyroid cartilage, where it may shift to one side, more commonly to the left. Duration of the symptoms. The lump may be present for many years before the patient comes to the doctor. It is usually an increase in size which brings the patient to a clinician. Pain in the cyst is almost always associated with the infection of the cyst. Systemic symptoms are never seen in this condition. Now the examination of the thyroglossal cyst position. A thyroglossal cyst may develop anywhere along the thyroglossal tract, starting from the foramen cecum to the isthmus of the thyroid gland, but accordingly to the frequency, its position may be as follows: subhyoid position below the hyoid bone. In the region of the thyroid cartilage may be deviated to the left side. Suprahyoid position above the hyoid bone. At the level of the cricoid cartilage, in the floor of the mouth, beneath the foramen cecum. Next examination of the thyroglossal cyst is the size and the shape. Thyroglossal cyst is the spherical or oval with the long axis along the thyroglossal tract. The cyst varies in the size from 0.5 cm to 5 cm in diameter. Due to the prominences of the swelling being in front of the neck, patient often present early even when it is small. Tenderness. The cyst only becomes tender if there is an infection. Consistency. Though it is a cystic swelling, yet the consistency is often firm or hard depending upon the tension of fluid within the cyst. Fluctuation test is usually positive. When the cyst is small, one Paget's test should be performed. Transillumination test may occasionally be positive, but due to the thick content with the epithelial debris, it is usually negative. Mobility. The cyst can be moved sideways but not vertically along the length of the thyroglossal duct, as the cyst is tethered by the remnant of the thyroglossal duct. The cyst moves with the deglutition because the swelling is attached to the hyoid bone by the fibrous tissue. The peculiarity of the thyroglossal cyst is that it moves up with protrusion of the tongue. This can be examined by asking the patient to open her mouth. The clinician holds the cyst with his thumb and forefinger, the patient is asked to protrude her tongue. The clinician will feel that the swelling slips out of his grip and moves up. Absence of this sign does not exclude the diagnosis, as majority of the cysts are below the level of the hyoid bone and easily loses attachment with the tongue, and so this test becomes negative. Next is the regional lymph node are usually not enlarged unless the cyst is infected. Now the differential diagnosis of this condition, that is the thyroglossal cyst, subhyoid bursal cyst. Though this cyst moves on deglutition, yet it does not move up with protrusion of the tongue. Moreover, this cyst has particular position with transversely oval in shape, whereas the thyroglossal cyst is usually spherical and differs in position. Second differential diagnosis is the sublingual dermoid is often difficult to differentiate from the subhyoid thyroglossal cyst. Again, mobility and deglutition of the protrusion of the tongue will help in this diagnosis. Now the complication, recurrent infection, fistula formation and carcinoma, though rare, may arise in the thyroglossal cyst. Mostly this is the adenocarcinoma of the thyroid origin due to the inclusion of the thyroid tissue in the wall of the duct. And the treatment, a thyroglossal cyst should be excised as a routine, as due to the presence of the lymphatic tissue in the wall, infection is inevitable. An infected cyst oftenly looks like an abscess, and incision will lead to the formation of the sinus. Excision of the cyst should also include any persistent portion of the tract, otherwise the recurrence is inevitable. The intimate relationship between the tract and the body of the hyoid bone exercises excision of the segments of the bone from the midline and make sure that this portion of the tract has been excised. Now the next point of this lecture is the thyroglossal fistula. Etiology, it is a never congenital. This acquired sinus or fistula originates from the bursting of an infected thyroglossal cyst. An incision on the infected thyroglossal cyst with the mistaken diagnosis of an abscess, incomplete removal of an thyroglossal cyst. Pathology, it must be remembered that though a thyroglossal sinus or a fistula is an acquired condition, it is the most always associated with the congenital abnormalities or of persistence of the thyroglossal tract. This tract is lined by columnar epithelium. This sinus is covered with a hood of skin with its concavity downwards due to the more growth of the neck as a whole in the comparison to that of the thyroglossal tract. This sinus often discharges mucus and is the site of the recurrent attacks of inflammation. Dear students, here is a good picture on your screen showing the thyroglossal fistula. This is the another image of the thyroglossal fistula. Now the clinical features, it is easily seen between the ages of the 15 to 40 years of age. The patient often gives history that the fistula closes by itself. After an interval of time, it becomes infected and painful, then it starts discharging with relief of pain. After a few days of the fistula closes again, on careful inquiry, one can get the history of presence of a previous swelling, that is the thyroglossal cyst, which was infected previously and subsequently burst with the development of the sinus, and somebody attempted incision of the cyst to drain it. Second clinical feature is the position of the fistula is usually in the midline, but varies. It may be either suprahyoid, subhyoid, or in front of the thyroid cartilage. The fistula may be infected with red hot surrounding skin. Otherwise, the skin around the fistula is usually normal. Next clinical feature of the thyroglossal fistula are characteristic features of the fistula is that it is covered with a hood of the skin or semilunar fold of skin just above the fistula. If the tongue is protruded, the fistula will be pulled up with prominences of the dimple. And the treatment of the thyroglossal fistula are the excision of the fistula along with the thyroglossal tract as far as the possible up to the base of the tongue is the treatment of choice. If the portion of the thyroglossal tract is left behind, there is a chance of recurrence. Presence of any ectopic thyroid tissues along the thyroglossal tract must be excluded, since excision of these thyroid tissues may lead to myxedema, since this may be the only thyroid tissues present in the body. The swellings which moves up with the deglutitions are, now this is the another point, the swellings which moves up with the deglutition, this should be known, and these are the thyroid swellings, ectopic thyroid, thyroglossal cyst, subhyoid bursal cyst or subhyoid bursitis, enlarged pretracheal lymph nodes which are fused to the trachea and laryngocele. Only thyroglossal cyst moves up also with protrusion of the tongue. This is the differentiation between the laryngoceles and other swellings of the neck. Now the cold abscess in the neck. A cystic lateral swelling of the neck may be due to the cold abscess, that is the cold abscess is an abscess which arises from the tuberculous origin. It is called cold as it is not as hot and red as pyogenic abscess. It is also much less painful and than pyogenic abscess. Causes of the cold abscess other than the tuberculosis are actinomycosis, gamma and leprosy. Actinomycosis, the pus from this fungal infection, is also cold in nature and is produces multiple sinuses. Gamma degeneration may produce cold abscesses, but this is the extremely rare. Leprosy, nodular leprosy may produce the cold abscesses from degeneration. And the etiology of the cold abscess is the cold abscess in the neck may be derived from the etiological sources from cassation of the tuberculous lymphadenitis in the cervical region. The cold abscesses is often seen in the anterior triangle from tuberculosis of the cervical spine. In case of the cold abscess is usually present in the posterior triangle. Now here is the image you can watch. There is a clear-cut picture showing the cold abscess in the neck. Pathology of the cold abscess in the neck from tuberculous lymphadenitis. Usually, one group of the cervical nodes is first infected. Most frequently, the upper jugular group of the lymph nodes is affected. The source of the infection is obviously the tubercle bacilli, and it is mostly the human type and not the bovine type that is the responsible for tuberculous cervical lymphadenitis. Second is from the caries, tuberculous spine of the cervical region. Cold abscess from the tuberculus of the spine may either rupture anteriorly or posteriorly. If it's rupture anteriorly, then when the cold abscess ruptures anteriorly, the pus will at the first lie deep to the prevertebral layers of the deep cervical fascia. Gradually it may follow one of the following tracks, that is into the superior to the mediastinum, into the posterior triangle behind the sternomastoid muscle, in the upper cervical region, in the lower cervical region, or in the axilla. If this abscess ruptures in posteriorly, then it comes into the spinal canal. From the here, it follows the anterior primary division of the cervical spinal nerve and appears in this posterior triangle. Now, the investigation is to be made in this condition, that is the cold abscess. These are the blood examinations. Show the anemia, leukocytosis with high lymphocytes count and the raised ESR, very diagnostic. Sputum examination may show the acid far bacilli. Aspiration of the abscess material should be examined in the following way, that is the Zell-Nielsen stain for acid far bacilli. Gram stain may be performed to exclude the secondary infection. Culture of the material for tuberculosis, guinea pig inoculation test, Montauk test is usually positive. Other lymph node biopsy to know the whether that is also affected by the tuberculosis or not. X-ray of the neck, anteroposterior and lateral views should be taken, and X-ray of the chest should be performed. Now the treatment consists of the general treatment and local treatment. General treatment consists of the antitubercular drug should be given according to the age of the patient. Good food, particularly high protein diet, is extremely necessary. Vitamin supplements should always be given, particularly B complex and vitamin C. Sanitarium regimen is necessary. Local treatment is aspiration and IND if necessary. Next point is the cluster abscess. This has already been described previously. It is the bilocular abscess with one locule deep to the deep fascia and another locule in the superficial fascia. Both the locules intercommunicate with each other, enter through a small perforation in the deep fascia. These may occur anywhere in the body. Types of the cluster abscess is the pyogenic and tuberculous. Pyogenic, when a pyogenic abscess develops deep to the deep fascia and gradually pressure points mounts so that the deep fascia perforates, the pus comes out into the superficial fascia. Such clustered abscess is more often seen in the hand, where deep fascia is the palmar fascia. Tuberculous cluster abscess, this is the more often seen in the neck from cassating tuberculous lymph nodes. The cold abscess beneath the deep fascia erodes and portion comes out into the superficial fascia. Next point of this lecture is the laryngocele. This is a narrow neck air containing diverticulum resulting from the herniation of the laryngeal mucosa. It may be located internal and external to the laryngeal skeleton. An internal laryngocele may displace and enlarge the false vocal cord and may result in hoarseness or airway obstruction. External laryngocele passes through the thyrohyoid membrane and present as a swelling in the neck over the thyrohyoid membrane. Laryngocele are more common in glassblowers, wind instruments, musicians and other who develops high intraluminal pressures. Dear students, here is a good picture showing the laryngocele. Internal laryngocele is clearly seen. This is the another picture of the laryngocele. Now the clinical features of the laryngoceles are, as mentioned earlier, it is more common among the trumpet players and persons with chronic cough. This is the smooth ovoid swelling, which is the tympanic. The swelling becomes prominent when the patient is asked to blow or perform the Valsalva maneuver. The swelling is boogy in feel and may be resonant on percussion. Sometimes the laryngosyle may fill with mucoid fluid and may become infected, in which case the term laryngosyle is more appropriate. There may be the hoarseness of voice. The swelling moves up with the larynx on swallowing. This is the coit diagnostic. Now the treatment of the laryngosyle is, the laryngosyles are excised through the transverse cervical incision. The sac is dissected from the surrounding tissues up to the point where it comes out through the thyrohyoid membrane. The neck is ligated and divided and the whole sac is excised. The membrane is repaired by the invaginating the stump of the neck almost like the stump of the vermiform appendix. Dear students, here is the end of our surgery lecture number 116, that is the diseases of the neck. Thank you.